Dr. Vivek? Yeah. Good morning, everyone, and welcome to the first conference of the anesthetist. I'm just going to actually tell you briefly how the day is going to go today. I know most of you have interacted on the group, Facebook group, so you all know them by their name, probably seen their faces on their profile, but today you have met them in real life. So we move from virtual to the real world. So we'll start today with our president, Dr. Vivek Gupta, who will actually give us the welcome lecture. Let us know how the whole society started and how we have moved in the last almost 2.5 years. Following that, we got few sessions. First of them is going to be started by our chief lecturer or faculty, Dr. Hazim Dazi, who has come all the way from Dubai. Dr. Hazim Dazi. Yeah. In the same group, we have Piyush and Naveen as well. And the session will be chaired by Rajesh Chawla, who will be here with us. He works in Apollo. And we will later on, during the day, move on to the echo and ultrasound in ICU. Will be presented by Piyush and Dr. Hassan. So it will be a hopefully very interactive session again. And in the afternoon, we move on to more of anesthesia. We'll keep telling you as we go around. Without wasting much time, I will likely ask our president, Dr. Vivek Gupta, to welcome all the delegates and the faculty. Thank you very much.
Good morning, friends. I heartily welcome you all to the first ever anesthesia conference that moves from virtual to the real world, Day-1 2014. The seed I sowed in 2012 has grown into a huge tree, which is now bearing fruits and providing shade to all those who seek its cover. It is truly heartening to see that a simple idea of interaction among anesthesiologists has so beautifully metamorphosed into the anesthetist. I can't help thinking, what an idea, Sarji. Like many others, I too felt the need for a platform to discuss issues related to anesthesia, like sharing experience, learning new techniques. Most important was the need for guidance in difficult and high-risk patients, and to seek help in an emergency. While books still remain the solid foundation of learning, and always will be, they do not provide an interactive environment. To this end, I started a Facebook group for anesthesia called Delhi Anesthetist. With pride, I recall it was an instant hit, fulfilling the purpose. Later, I realized that need of such a group to cover all of India, and hence created Indian Anesthetist. To manage such a venture, however, I knew I needed someone who was academically sound, could satisfactorily answer questions raised by members, and was passionate about disseminating knowledge, especially about latest advances in anesthesia. Around February 2012, I chanced to come across Dr. Shiv Kumar Singh on Facebook, and was instantly impressed by his grasp, deep insight, and wide knowledge of anesthesia, and also by his way of answering the queries on another group. I requested him to take reins of Indian Anesthetist and carry it forward, to which he kindly agreed, and in turn suggested not to tie the group down with any kind of limitations, but make it universal. Therefore, Indian Anesthetist became the Anesthetist. Under Dr. Shiv's dynamic leadership, the group progressed in rapid strides and has now become one of the most sought after groups in anesthesia. Eminent anesthesiologists from all over the world have joined the group and are lending their expertise. Incidentally, Dr. Shiv, whom you all adore, is a multi-talented personality. Besides being a top anesthesiologist, a teacher, he is also a great designer, dancer, and a DJ. Soon enough, we simply became an extended family. All of share equal status and respect, irrespective of age, designation, or seniority. All queries, however minute, are promptly answered. No one is allowed to feel humiliated or belittled or made to feel left out. After such a long virtual friendship, our members were getting impatient to meet in real world, and thus TechOn, the anesthetic conference, was conceptualized, and it is now a reality. The group has been converted into a society, namely the Anesthetics Society. Arranging such a conference is always a Herculean task, especially for the anesthesiologists with endless OT lists. But despite such constraints, everyone was ready to find out time. A busy work schedule was no constraint for Dr. Anil Sharma, who volunteered to take responsibility for organizing such a conference. With pride, I can assert that he has done a wonderful job, and that without his sustained efforts, it would not have been possible. I wondered how he managed it with his grueling schedule at Apollo Hospital. Dr. Hetal Vadera, another active member who has prior experience of conducting a conference at Rajkot, also chipped in and was made the vice chairman of the conference. The combined strength of the experience of Dr. Hetal, hard work of Dr. Sharma, and the complete support of Dr. Shiv set the ball rolling. No such conference, however, is possible without deep pockets of financial support, and we need large funding. This was made possible by the gracious gesture of the Executive Committee of TAS. We generously contributed the seeding fund for the conference. To them, we owe our special thanks, for without that base, today's reality of the conference would not have existed. The members of Mastiki Toli, though being very must, are also very serious about their work and responsibilities. Inspired by the leaders, everyone started contributing to the cause by offering a suggestion, arranging funds, extending a helping hand to Dr. Sharma. It won't be wrong to say it is that MKT members who provide the momentum to keep the show going. So dear friends, without taking more time, I again welcome you to TechOn 2014. Let's make it a grand success. Thank you.
Thank you, Dr. Vivek Gupta, for that nice welcome and brief history of the Anesthetic Society. Next, what we're going to do is, unlike any other organization or any other conferences, people come meet. Okay, a lot of us don't even know who were there. Here, we know everybody by looking at the profile, face. Sometimes, it's been surprises. It has been total surprises, I know. Okay, so what we'll do is start introductions, okay? Like I sent on the Facebook group, a brief introduction, who you are, where you work, what kind of work you do, okay? So a brief introduction, okay, so that now people again recognize you by your real face rather than a virtual face, okay? I can start with Dr. Hazim Dazi, okay? Bhaiya, mic. He's not only our first speaker, he's one of our foreign delegates. Okay, he's come all the way from Dubai. So just a few words, Dr. Dazi, it will be great for us.
Thank you very much. My name is Dr. Hazim Daji. I am anesthetist, intensivist, and an emergent medicine doctor.
All in one.
Yeah. So I work at the moment in Sharjah in the United Arab Emirates, running the Department of Anesthesia and Critical Care with Dr. Piyush together. He joined us recently, 2 months ago, and I am happy that he joined our hospital. So that's in short about me.
I've actually asked Dr. Dazi to actually hold the 2017 the anesthetic conference in Dubai. And he said, no, why not?
Yes, why not? Why not?
Why not? Why not?
I don't think if we can realize such a huge effort, what we have done here really in India, really it's a huge effort. We will do our best, me and Dr. Piyush, to realize this. But
Dr. Vivek Gupta.
I am Dr. Vivek Gupta. I work in Maharaja Agresyan Hospital and Saroj Hospital as an anesthetist in Delhi.
Go on.
Good morning. I am Dr. Surojit Giri from Assam. That is 390 kilometers east of the Guwahati, at a small district place. I am anesthetist and in charge of 6-bedded level 2 ICU. Thank you.
Good morning, everyone. Firstly, I feel immensely privileged to be here and to see you all. I'm Senthil Kumar Muthu. I work pretty much about 15 miles from where the big boss works.
Liverpool team.
Yeah, so I can't escape from him, basically. Yeah, I work as a consultant in a hospital called the Viral University Teaching Hospital. My area of interest is regional anesthesia. I'm the lead clinician for regional anesthesia and acute pain in that hospital. I was trained, basically, my undergraduate from Annamalai University, where Pooja also trained from. My post-graduation from Bangalore, and then I worked in Sundara Medical Foundation for 5 years, and then moved on to UK, and here now today. Yes.
My name is Tushar. I think I'm sitting in the wrong row. I should sit behind.
Why?
Because too much to follow, you know. I'm a bit too young as well. I work in the United Kingdom. I work in a hospital called Wiston Hospital, which is a teaching hospital. I'm a consultant, recently appointed, and I have been trained by none other than the master himself, which was my final year of training. Currently, I'm working in regional anesthesia, and my specialist interest is regional anesthesia and preoperative medicine. And I've very recently been appointed as the lead for FRCA training in Mercy School of Anesthesia, which is in Liverpool.
Good morning. I am Dr. Pawanjit Bali from Jalandhar. I am in Jalandhar since 1978, practicing as freelancer. So my area of interest is mainly obstetrics, and 90% of my work is obstetrics. So I have seen a lot of history of anesthesia in Jalandhar. I started from 40 rupees a case for cesarean. Now I am charging 2,000. So I feel, and I think this is less. I think this is less. It should be at least 10% of the total surgical fees. At least.
Yeah.
So I feel very young. Otherwise, I am a graduate of 1975. I passed out from
Wow.
MGM Indore.
Amazing.
Thank you.
Amazing. We have to see, I think, who is the senior most here then.
Good morning.
Oldest doesn't matter. Okay, you can be old, but you have to be young by heart.
Hello, good morning everyone. My name is Nevin. I work as a consultant intensivist in mid-north coast of Australia. I'm originally from Kerala, did my undergrad training in Tamil Nadu in Stanley Medical College in Chennai, then did postgrad in PGI, and then had a very short stint in Middle East, and then moved to Australia. Yeah.
Hi, good morning. My name is Piyush Malik, and I think all these issues were started with me because I am the one who brought him to the Facebook, and I am the one who started a ICU.
Come on.
So anyway, I'm presently based in Dubai. I work with Dr. Hazim Dazi as an anesthesiologist consultant, and I do cover sometimes ICU, because ICU work has decreased which my predominant, primary interest is ICU. And I was trained in echocardiography. My guru is sitting here.
Hey, Dr. Hassan.
He is the one who brought me to ultrasound world. And then, I do a bit of regional, and that's it. Thank you very much.
Welcome, Piyush. Dr. Hassan.
Good morning.
Yes. Sir.
Good morning. I'm the odd man out, I think. I'm the only non-anesthetist.
Yeah, it doesn't matter. That makes you special.
Yeah. My wife has come with me. She's not a doctor. She's a teacher for the last 30 years.
Welcome, ma'am.
And my life in cardiology started in New Delhi. I worked way back in 1975-76 period in GB Pant Hospital.
We were in our chuddies.
Then I told Dr. Padmavati I'll go for 2 years and come back. It's now 40 years. I work in Kuwait right now. Piyush had come to Kuwait. He's an excellent, I don't want to call him a student, but a great chela and a nice person who brought Facebook into on our faces, and we are happily here.
Thank you, sir.
Hello, friends. I am Dr. Daljit. I am working presently with Delhi Government Health Services in a small 30-bedded hospital. I am a lone anesthetist, and I guess out of all of you, you are all belonging to corporate hospitals or private practice. I am the only one which is from the government sector. Is it?
You might find some more, I think.
Oh, hello.
Yeah, there are a few there, yeah.
I have been practicing just general anesthesia and regional anesthesia, but with IORA coming into picture through Facebook only, I'm moving towards regional now.
Fantastic.
Thank you so much.
Thank you, Daljit.
I'm Sai. I've just finished my senior residency from All India Institute, and now I'm working as an assistant professor at Hamdard Institute of Medical Sciences and Research. Thank you.
Thank you, sir. This is Pooja.
Hello, I'm Pooja and I'm from Chennai. I work at SRM Institutes of Medical Science. It's a new hospital coming up at Vadapalli in Chennai. And I'm very happy to be here, and thank you, Dr. Shiv. I mean, like, Surendranath and me and Dr. Sudhakar, we are three of us from the same institute. We came to, we came in touch with the Facebook group maybe like very, very recent in April this year. And Dr. Shiv was kind enough to come down for a conference in Chennai, and Dr. Gurunath, just through Facebook, and now we've come and joined this big family. Thank you.
Welcome to you. This is Surendra. Yes.
Good morning, everybody. I am Dr. Surendranath. As she had given the introduction, I am from SRM Institute of Medical Sciences. My primary interest is on regional anesthesia, transplant, and neuroanesthesia. And I love cooking, swimming, and skating.
Oh, that we didn't see that.
Thank you.
Next time.
Hello, good morning. I am Deepti Mehta from Rajkot. I am in a private practice since 1997, and I usually work for Euro and Ortho mainly. Thank you.
Welcome.
Hi everyone, I am Darshana Dikshit. I am presently based at Surat, but I have been moving around quite a lot. So this is my fifth city to be in. But there was a phase when I was doing only cardiac, but now I do mainly onco and other things. So thank you. Very happy to be here. Yeah.
Oh, great.
I am Dipali Rathod from Anjar, Kutch, Gujarat. And I am working as a freelancer, and my special interests are surgeries in obstetric and gynec, and pediatric surgeries.
Oh, okay. Good. That's good. Nice. Yeah.
Good morning, dear family. Dr. Pankaj Gupta from Nasik, labeled as an anesthetist activist by the surgeons of Nasik. And I've tried to bring about quite a few changes in the city. I'm happy that it has been recognized not just by all of us here. Since yesterday I've been meeting so many people, it has been really feeling very great. And I feel happy that whatever little bit of work I did in Nasik was recognized by the national body, and our national president has been copywriting everything and circulating it all over the country. And yes, it feels great to be a part of this family, and I feel I just would like to add a few lines as what can we should have a fixed aims and objectives of tasks, and these aims and objectives should be put on paper and maybe work as a pressure group to the ISA, because all of us are here are a little bit disgruntled about the situation that we are, all of us are in.
ISA, he want to kill us. I Prema.
No, I mean, we work like a pressure group. We lay down some resolutions, and those resolutions I feel should very well be read out in the general body meeting of ISA at Madurai, and I'm sure 20, 30 of us will be there, and
that
we work
can be done. We'll do it through you.
Great, no, definitely, anything. I'm sure many of us will be there.
Well, thank you.
So I feel that will be the best thing of all of intention of all of us coming together. Thank you.
Yes, sir. Together we can achieve plenty of things. Good morning, all. I am Dr. Vikas Chawla. I work for the Defence Forces. I don't have a special area of interest as such, and presently I am posted in Military Hospital, Allahabad, and I play virtually all sports. Thank you. Icons of Tech-On. Thank you so much.
Absolutely. Fantastic. Guru.
You need my introduction? My name is Guru, and my primary specialty is to just oppose Shiva.
No, he is the best critic I can ever have. It's very, very important to have a critic. And yes, anybody, you can please anybody by agreeing to what others are saying. It requires, I won't say guts, but it need to be really clear of heart to be able to actually say that no, you're wrong, or this is not the way it is. And that's very, very good. My best critic.
And I was quite pleasantly surprised what my image was otherwise. You know?
It's changed now, huh?
Thanks to take on.
Great. Thank you, Guru.
Hello, everybody. Good morning. I am Dr. Harsh Patel from Bhavnagar, Gujarat, and I came to know about Take-On since last 3 to 4 months when I got registered in this conference. My main work field is orthopedics and gynec, and I have passed my MBBS and MD from Baroda Medical College. So I am working in Bhavnagar since 12 years. Thank you.
Thank you.
Hello everyone, my name is Parthiv Chauhan. I am working as a freelancer in Bhavnagar, Gujarat. I have my special interest in orthopedics and gynec. Thank you.
A very happy morning to everyone. Myself, Dr. Jayesh Rathod. I came from Anjar, a small town in East Kutch, Gujarat. I came here with my wife, Dr. Dipali Rathod. My area of interest in obstetrics and orthopedics, mainly regional anesthesia. I did my post-graduation and undergraduation from Sri Empisa Medical College, Jamnagar, and now working as a freelancer in Anjar and Gandhidham, Gujarat, which is my hometown also. Thank you very much.
Dr. Prema.
Yeah, I'm Prema. I think I'm the oldest. Thank you. I think I'm the oldest person in this crowd.
It doesn't matter, you are the youngest.
I'm so happy, so excited to be here in Delhi with all of you, especially my good old friend from JIPMA. I am from JIPMA undergraduation. Post-graduation I did in Madurai Medical College. I belong to Madurai. I stay in a place near Madurai. I retired from Tamil Nadu State Government Service 2 years ago, and I started an anesthesia association, the only thing about which I can be proud of. I'm the secretary of the association. I have about 25-30 anesthetists with me. We conduct periodical CMEs at our level, and we have workshops and all that. We try to do something scientific. I can't afford to have any area of interest because I'm a freelance practitioner now. Whoever calls me, I attend the cases, and I do my best. Thank you.
Hello, I am Dr. Jayesh Parmar. I did my post-graduation from Grant Medical College. Right now I am working at Raipur in Chhattisgarh, and my maximum work involves laparoscopic surgery and neurosurgery. Thanks.
Good morning. It's a pleasure to be here with all of you. Finally, from snaps to live feed, I can say that. I'm Sumit Kalra. I'm working currently with Max Saket. I did my post-graduation from GMC Bhopal and my neuro anesthesia training from Hinduja Hospital, Mumbai. Thank you so much. It's a pleasure meeting you all.
हम क्या बोले? It's a great pleasure to be here. Absolutely, I am so thrilled. I am working in a place called Muzaffarpur. It is about 75 kilometers north of Patna, And mainly I'm into ICU, dealing with cardiac and neuro patients. I do give anesthesia mainly to orthopedic surgery and general surgery.
And to the politicians.
And to politicians, mafias, queens, dons, coming with guns, goons.
Yeah.
And my special interest, बाद में बताऊंगा.
Good morning, everyone. I am Partha Saikia from Al Jara Hospital, Kuwait, and my interest is regional anesthesia, which is ignited by Piyush sir, who is my guide.
Oh, very good. Excellent.
Thanks.
Excellent.
Good morning, everybody. My name is Dr. Harsh. Basically, I'm from Agra, but currently I'm working in Al Jara Hospital, Kuwait, and I'm graduated from SN Medical College, Agra in itself. Before I was working here in Delhi, Safdarjung Hospital.
Okay, very
Just last 1.5 year I'm in Kuwait, and my primary interest in regional anesthesia, no doubt. Thanks.
Yeah, that looks like it must be a very popular thing. Yeah.
Good morning,
Sunny,
friends.
Sunny, I would want you to come here. There's a special reason for it. I'll tell you in a minute. Okay, before we let Sunny introduce himself, okay, we'll tell you that the logo you see here, okay, of the anesthetist was designed by Sunny. Sunny, especially for you.
Thank you.
Yeah.
Thank you.
I mean, the guys who we got these posters and things may say, how complicated can this be? We can't replicate it. Please send us the original. So it is got everything in it about anesthesia, you know, what we do. It's a very nice logo. Thanks, Sunny.
Thank you, sir. So starting with the logo, I made this logo going through the guidelines made by Dr. Shiv. He had already dictated, written everything on the Facebook. I just followed his instructions, and a star came to my mind, and I did everything in the star according to his guidelines. So I am from a very small place, Jabalpur. I am a freelancer there, and I am trying to do big things because my family is now very big.
Yes, absolutely, absolutely. I think that the family gives you the power to do things, isn't it? Amazing things, yeah, absolutely.
And area of interest is, I just like to compare one scenario of life. It's like a person you love and a person you are married to. They are not always same.
Okay.
But I am lucky enough. I am working mainly in trauma, and my field of interest is regional anesthesia.
Fantastic.
Thank you.
Soma Ganesh.
Hello, I am Dr. Soma Ganesh, working as anesthesiologist in Sri Ramchandra Medical Center since past 5 years. My area of interest is preoperative medicine, postoperative pain management, and regional anesthesia. Thank you.
Thank you.
Good morning to all. I am Dr. Venugopal. I am from Kerala. I am working as an anesthetist in a group, in a charity hospital. We are a group of 4 people, and my main interest is in acute pain service.
Hello friends, I am Dr. Deepak Madankar from Nagpur. I am working as Chief Consultant Anesthesiologist at Mediterranean Institute of Medical Sciences at Nagpur. I did my UG as well as post-graduation from GMC Nagpur and post-PG senior residency from PGI Chandigarh. And my areas of interest are neurosurgery. Right now I'm spending most of my time in neurosurgery, neuroanesthesia. And I'm extremely happy and excited to be part of this group and looking forward to have good things.
Thank you.
Thank you.
Hi everyone, I'm Nilesh Mathankar.
Oh,
and hi sir. And I actually don't know where should I belong to or where I do belong too.
You belong to
because-
India.
Yeah, I belong to India, you can say. I basically belong to my hometown is Batul in MP. It's a small place. I did my graduation and post-graduation from Medical College Jabalpur. And later on, I came to Delhi, worked in so many different hospitals. I worked with Vivek sir for some times. And then I shifted to Nagpur. And currently, I am working there in a mainly neurosurgical hospital along with Dr. Deepak Madankar. So I am spending, like he said, most of the cases like neuroanesthesia.
So you spend your life in the theaters then?
Mostly.
It can be quite long. I remember from our training, neuroanesthesia means you was there for a very long time.
Yeah.
While they pick up each and every grey cells.
And the RBC is not to forget.
Yeah.
Okay, thank you.
Yes.
Good morning, everyone. I am Dr. Mehdi Hassan. I am from Bangladesh. I am doing my.
Excellent.
Thank you. I am doing my MD in Bangabandhu Sheikh Mujib Medical University in Dhaka City. My point of interest is critical care medicine. Thank you.
Mehdi, we would like you to come here. This is a special gift from India for you.
Thank you. Thank you very much.
You made so much efforts to actually be here with us, all the way from Bangladesh. Thank you very much.
Thank you.
Good morning, everyone. Myself, Dr. Nishit, and I am working at Sunshine Global Hospital, Baroda. I had done my PG from Karamsad, Pramukh Swami Medical College, and I am feeling very much proud to be a part of anesthetics because it helped me a lot. Thank you, Shiv sir.
Thank you. Welcome, Nishit.
Good morning, everyone. I'm Dr. Amit Jain. I'm basically from Jaipur, Rajasthan. I did my post-graduation from NHL Medical College, Ahmedabad. Same where Dr. Chintan Vyas and Dr. Anil sir.
Yes, there is a big contingent from the Gujarat. Okay, so a lot of Gujubais are here and bands.
I'm post MD. I'm doing freelance practice, and my area of interest is regional anesthesia and ultrasound guided regional anesthesia. I haven't done anything yet, but I'm looking forward in future to do something big under this family. Thank you.
Amit and Chintan, what we'll do now is that we will likely, you guys need to be introduced. We will let you introduce later on. Okay. The reason being that we have to start the session now. Okay. And because Rajesh Chawla, he's our moderator for this morning. Welcome, Dr. Chawla. He is an intensivist at Apollo Hospital, and he's a very busy man. He's also president of the Indian Society for Critical Care Medicine. So he's a past president, and he'll be chairing our today's sessions for the ITU. The first session is by Dr. Hazim Dazi, and he'll be talking to us about pulmonary embolism. Okay, something which is very, very important for us. Okay, it's one of the most preventable cause for postpartum mortality. Yeah. Okay. Oh, sorry. Yeah. You want to start with? Hazim, can you just have two minutes? Okay.
Any function can't start without a chief guest, and our chief guest is here only, and he is one amongst us. Usually you would have seen chief guests coming like this. So next slide, please. Next. Okay, so he's not like this. He's one amongst us, and we want doers. Basically, our conference is of people who are actual doers in their fields. So the guy is here, and please welcome Dr. Abhijit Dam. So he is the chief guest of the function. Just a brief mention about him. He is our anesthetist who has given up, who is totally into public service. You know, he has constructed a hospital from his own pocket. 15 lakh he has spent. And the best tribute was paid to him by his patient who said, "Before I die, call my doctor, please." and then he drove all the way 600 kilometers to meet him. So such is the dedication, and I think this due credit should go to him to inaugurate our function. Thanks a lot.
टाइम ऑन करो 20 मिनट रखनी क्या 20 नहीं यार 30 गलती हो गई
Women power is very, very important. Yeah, everybody is, you're the force behind everyone.
So again, good morning, everybody. Thank you very much, Anesthesia Society in India, to invite me to be here, a part of this conference. I really feel after only one day to belong to this family, really. We had a very excellent, nice day yesterday where we were introduced to each other, and really I feel already I know everybody since long time. Thank you very much for inviting me again. Pulmonary embolism. It's actually a very important subject. We usually talk in conferences about septic shock, ARDS, and all these, and we leave a very important other diseases where we don't talk about, such like pulmonary embolism. Okay. Thank you. Many of us will think maybe he's talking about pulmonary embolism. Everybody knows anything. Everybody knows everything about pulmonary embolism, but this is not true. We have to go through such a huge subject up and now again to remind us what to take care of, how to take care of such patients. I know it's easy to say pulmonary embolism, every patient with dyspnea, chest pain, pulmonary embolism, ICU, but many of patients dies every year because of pulmonary embolism, because of wrong diagnostic, wrong treatment. So that's why I will go through pulmonary embolism in a quick way, in a simple way, that only to remind you about basic things. So as I said, pulmonary embolism is a common cardiovascular disease. It's maybe the third important or huge after MI and stroke. It's a very difficult diagnosis because the symptoms of pulmonary embolism are the same symptoms for many other diseases presented in the ER. Why it's very important? Because the early diagnosis, the early start of treatment is very important to save lives. If you delay the diagnosis for half an hour or 1 hour, you delay the treatment for 2 hours, then we lose many of patients unnecessarily. I checked in the net. We have in the United States of America 50,000 deaths per year after a pulmonary embolism. In Germany alone, 40,000 deaths per year. So it's a huge number of dead patients which we have might save their life. Only to know the right diagnosis and to start the treatment in the right time. So many of us diagnose the wrong patients. We have a patient with chest pain, dyspnea coming in the ER. Many of studies has proven that 60%, up to 60% of these patients were wrong diagnosed. That means patient come in the ER, chest pain, dyspnea, we diagnose him wrong, we treat him wrong, and he dies. After he dies, we become to know, oh, he had pulmonary embolism. So these mistakes should not happen, or at least as less as possible. We should really take care of these patients. So if we look to pulmonary embolism patients, we can divide these patients in several groups. 40% of these patients, they are idiopathic. We don't know the reason getting a pulmonary embolism. A huge number of these patients had surgery recently before getting pulmonary embolism. And that's our interest of group here. Post-surgical patients, 43% of pulmonary embolism patients had a surgery recently before getting this pulmonary embolism. 12% heart disease and systemic disease only very rarely. So this is the one study I wanted to show, just short. In Brasilia, they have done a study. They have done autopsies for nearly 4,000 patients in a range of 12 years, 1980 till 1990. And they have seen that the same, what we have discussed before, 40% of pulmonary embolism patients were idiopathic, surgical 40%. So when we look here to this diagram, after autopsy of the patients, which was given as a pulmonary embolism patients, we see a huge number of these cases were autopsied, were investigated, and there was no pulmonary embolism. And the patient who had pulmonary embolism were diagnosed wrong. So that means we, in this hospital or in this country, for over 10 years, they were diagnosing the wrong patients, treating the wrong patients for pulmonary embolism, and this is the target of this lecture. This should improve, this should change in the future in the ER, in the anesthesia, in the hospital, that we should give the correct diagnosis, give the right treatment to the right patient. It's not easy, I agree, but that's why we have to remind each other up and now about such huge subjects. What are the diseases? They have found that many other diseases have the same symptoms like pulmonary embolism. That's why we are misdiagnosing these patients. Heart failure, pneumonia, acute MI, a lot of other diseases have the same symptoms. So that's why it's difficult. Again, the same results of the statistics. So why do we need a prompt diagnostic? It's giving the wrong diagnosis and the wrong treatment is a leading cause of unnecessary death. Many patients should have not died because of wrong diagnostics. For such a huge, well-known disease, pulmonary embolism is one of the main basic subjects in the medical studies, and we still doing the wrong diagnosis. Some of the doctors in the ER treating patients like that, okay, patient has chest pain, little bit dyspnea, shift to the ward, let us wait and see what will happen after 2 hours. So this should not happen. You should diagnose the patient in the ER in the first 30 or 1 hour maximum and start treating him. So now I am coming actually to the basics. A pulmonary embolism is a blockage of one of the pulmonary artery with a blood clot, fat, air bubbles, and so on. So our main target is the blockage of the pulmonary artery. We have, of course, risk factors like all other disease. The most important ones, advanced age, the pulmonary embolism risk is with higher age, of course, more. Blood clotting disorder, cancer, MI patient, atrial fibrillation, written problem, major surgeries, obesities, paralysis, many of other risk factors. So this is maybe pulmonary embolism has more risk factors than MI. So other societies in Europe, they are giving strong predisposing factors, medium and low risk factors. The strong factors are fractures. Most important is hip and leg in the orthopedic area. We have a lot of elderly patients with a hip fracture, and they are really at very high risk of getting pulmonary embolism post-surgery. Moderate risk factors, small surgeries like arthroscopies, putting a central line, chronic heart or malignancy, these are a moderate risk factors getting pulmonary embolism. So what are the symptoms of a pulmonary embolism? It depends on the size of the artery was blocked at this moment, at this stage. If we have multiple small arteries were blocked, you might have a patient only with a slight dyspnea. No chest pain at all, no cyanosis. If you have a huge artery, bigger artery, you might have dyspnea up to severe dyspnea with cyanosis. You can have severe chest pain. So of course, the more sick your patient is, the more symptoms you will have. If you have a 90-year-old patient with atrial fibrillation, with hypertension, diabetes, he will have more symptoms. His compensation mechanism is much lower than other young people. Actually, pulmonary embolism symptoms come suddenly. You don't develop a pulmonary embolism over the last 2 or 3 weeks, like hypertension, pulmonary edema, and so on. So it develops suddenly, and you have suddenly chest pain or dyspnea. As I said, we have multiple symptoms. Tachycardia, it's very difficult. Some patient has tachycardia, some patient do not have. It depends on the size of the pulmonary embolism. Dyspnea, tachypnea, chest pain, cough, hemoptysis sometimes. And if we have a big pulmonary embolism, we might get acute circulatory instability, hypotension, up to shock. Now, some of the hospitals did studies and found out that 96% of the patients who have pulmonary embolism have tachypnea. Only 53% of them have a second heart sound, like 44% have tachycardia, and so on. That means many of your patients will come to the hospital will not have all these symptoms together at once. They might have 1 or 2, they might have all these symptoms together. So that's why it's very important really to be careful and to investigate properly. So the pathophysiology is very important. What is the key behind the what's going wrong with a patient with a pulmonary embolism? The main factor making the patient sick with a pulmonary embolism is the acute right heart failure. After a blockage of the pulmonary artery, we have an increasing in the resistance in the pulmonary artery. This leads to pressure increasing in the right ventricle. And if we have a huge blockage of a huge pulmonary artery, we have a severe acute right heart failure. This leads to hypotension, indirect left ventricular failure, and then we have a patient in cardiogain shock. Most of the ER doctors will think this will be a MI followed with cardiogain shock. So that's why we have to differentiate here. Of course, the patient, why does the patient have a dyspnea? Yes, this has 2 reasons. Once we have a blockage of the pulmonary artery, we have less oxygenation in this area. That means oxygen will come less in the body because this blockage has failed a part of the lung. And the second one, the shock, the hypotension, and the right heart failure, and indirect left heart failure then will lead to hypoxia also. So that's why the dyspnea. So sometimes we have relatively stable patients, we admit them, we treat them, and in the next 2 days they develop more heart failure, and they have maybe recurrent small pulmonary embolism. This leads to increasing of the symptoms again. One more important thing, in 30% of the population, they have all of them still open foramen ovale in the atriums, and after increasing the pressure in the right ventricle, this leads to increment of the pressure in the atrium, and this leads to a shunt, and this leads also to hypoxia also. For the diagnosis, it's very important the medical history. Many of our colleagues at the moment in the ER, patient comes in the ER, they don't even touch the patient. They sit beside him. Yeah, I have chest pain. Send to CT scan. Okay, do an ultrasound, do a lab investigation, and he never looked to the patient. This is wrong. Clinical judgment is very important. You have to take the history from the patient. You have to ask in details. If you suspect a lung embolism, pulmonary embolism, you have to ask certain questions. Did you travel in the last 2 days? Did you have a surgery in the last 2 weeks? And all these small questions, you might not even need for any mechanical diagnostic way. Simple questions, simple answers may lead you to the proper diagnosis. So, of course, after we take the history, we do a routine blood work for the patients to rule out other things, of course, yes. For pulmonary embolism, arterial blood gases for a patient with a small pulmonary embolism will not lead me to the diagnosis. But I need to do this to rule out hypokalemia, hyponatremia, other things which may be necessary to treat also in the same time. So we have many scores which help us to diagnose a pulmonary embolism. I've chosen only the 2 most common ones. One is the revised Geneva score, very simple questions, the age, previous history, surgery, malignancy, and so on. You put the points number, you add them, and you have a probability of risk of the patient. Low risk, high risk, intermediate risk for having pulmonary embolism. So it's a thing of 10 seconds, you can answer this, and if you don't know proper clinical judgment, you don't have a proper clinical judgment, you can follow these small scores. The other one is the Wells scores. It's the same, simple question, simple answer, point, additional. So another diagnostic, ECG. Yes, every patient comes to ER, gets an ECG, chest pain, ECG, first of all. So I never diagnosed pulmonary embolism from the ECG before. It's very difficult. You can, rarely, in 20% of patients, see the signs of pulmonary embolism. Maybe in a huge pulmonary embolism or in the late stadium, maybe after 1 or 2 days, but not immediately. So I don't use ECG to diagnose a pulmonary embolism. But the patient with chest pain gets an ECG as a routine. Chest X-ray, also chest pain, everyone gets chest X-ray. It's also not clear. You might see some small changes 2 or 3 days after the acute phase, but not immediately. So one excellent diagnostic method is the lung perfusion, lung ventilation scan. We have this in our facility. It needs time. You have to send the patient to the nuclear scan department. They have to take history, they have to take consent, they do the investigation. It takes around 1.5 hours. And then you get result, and the result will say, most probably, but we don't know. So it's still not giving me the 100% reason to treat the patient. But in cases where you have a small pulmonary embolism or a multiple minimal risk factors, you have time sometimes to do this scan also. The most important diagnostic way for investigating a pulmonary embolism is the angiography, the CT scan. So you send the patient to the CT scan. Within 3 minutes, CT scan is done. You inject your contrast metal. You have definitely an answer, yes or no. This is the only way where you can diagnose a pulmonary embolism. Now we have a new method. I read about it. We don't do it in our hospital. Computed tomography. So this involve the ECG of the patient during the CT scan to evaluate the heart function during the CT scan. So it might be the future, but I still don't need it. Angiography, a computer CT scan with contrast is more than enough to diagnose the pulmonary embolism. And it takes 2-3 minutes, not more. Some of the guidelines now suggesting, we had many names for embolism, massive, submassive, non-massive. Some of the guidelines suggesting now to change this in a relation to the risk of the patient. Lethal pulmonary embolism, non-lethal. Fatal, non-fatal. This is, we are trying to make it as easy as possible. So, according to the new nomenclature, we have a high risk for lethality, we have a non-high risk for lethality, and it's dividing according to the heart function. You have a shock plus right ventricular dysfunction plus a myocardial injury, you have a high risk for high lethality of the patient, and the others are non-high risk. So for every disease there are such a guidelines where you can follow also simply. Patient comes, suspicion of pulmonary embolism, CT scan, yes or no. You see echocardiography, yes or no. You follow these simple steps. But if you want to take such a diagram for each disease, you will have a book in your pocket all the time. So it depends the area where you work in. If you are working in a busy hospital with a lot of orthopedic surgeries, maybe you have to have this in your mind. Otherwise, actually it's very simple, very easy. Patient with suspicion pulmonary embolism, CT scan, yes or no. Echocardiography, yes or no. I forgot to mention for the diagnostic before, maybe the echocardiography. Echocardiography is very important. Now a lot of our anesthetists can do themselves echocardiography. No need to wait for the cardiologist to come and do himself the echocardiography. Not all of us can do this. I cannot do echocardiography, so I call our colleagues. They do this, and also in 2 minutes we can see the condition of the heart immediately. This helps a lot to evaluate the grade of the pulmonary embolism. So how to treat such a patient? Now we are coming to the treatment. We treat the symptoms first of all. So oxygen, of course, patient with dyspnea, you give oxygen. Actually every patient comes to the AR, he gets an oxygen mask, whatever he has. So this becomes a routine. He has a chest pain, we have to relieve the pain. So very important. We have to prevent the patient from getting a secondary pulmonary embolism or a secondary DVT. So we have to hyperinize the patient. This is in short way treatment. I'll go for one by one a little bit more in details. We have the possibility to put a filter in the vena cava. We have to ventilate the patient if necessary. We have to give catecholamine if needed also. So now we'll go step by step. Supplementary oxygen, as I said, gets every patient with dyspnea. Severe hypoxemia, you have to see the ABG, decide, shall I put the patient on a ventilatory support or no need? Now the problem putting a patient on ventilator is always there for all diseases. As soon as I give propofol or fentanyl to a patient to put a tube inside, blood pressure drops. Now I have a patient with a hypotonic shock, blood pressure is already 80, and I want to sedate him and put a tube, so I have to think about this properly before doing it. And when I do this, I have to be ready to give catecholamine support immediately, because they will drop definitely with the blood pressure. So the second point is the hemodynamic support. Of course, I cannot leave the blood pressure 80/40 or 70/30 for a long time. I have immediately to treat the hypotension. The first step has to be done in a hypotension base is giving fluid. I know the cardiologist will say maybe, no, don't give fluids. He will get a more shock. But the first aim in every hypotension patient, give fluids. 500 ml of fluids will not harm the patient, even if in a cardiogain shock patient. And you can evaluate, is he hypovolemic, is he not? So you can treat the patient accordingly. So first of all, you give him a 500 ml of normal saline and see his action. No, the blood pressure still is low, doesn't improve. you have to start catecholamine. So for hypotension in such a shock, not working? Can everybody hear me? No problem. Okay. So we start catecholamine. We usually start with norepinephrine. Yes. We usually start with norepinephrine. It makes less tachycardia, our experience. We give the butamine as a second choice. The butamine decreases the resistance in the periphery. First of all, in the pulmonary artery, I need to decrease the resistance in the pulmonary artery. It may help the flow to be better in the lung. So norepinephrine, dobutamine are the first choice. Of course, if we have a severe shock, severe hypertension, we can start dopamine also, and we can start epinephrine. So this is now a very important sentence. We have to anticoagulate all suspected pulmonary embolism patients already in the ER. Before I do the diagnostic, before I send the patient to the CT scan, if I am sure that the patient is having a pulmonary embolism, I excluded main other things, I have to give heparin bolus in the ER already 5,000 to anticoagulate the patients. Diagnostic should not delay any treatment. So as soon as I give the heparin, I might have saved life of the patient. So in simple ways, oxygen, ventilation, catecholamine, anticoagulation. These are 3 simple steps. You do them in the ER and you save many lives of patients with pulmonary embolism. So now we have many guidelines, books of guidelines, around 50 pages only about anticoagulation, in which area and how the doses. And each country has different guidelines according to the needs and the availability of the medication. I'll tell you what we do in our hospital. We give heparin, 5,000 unit, bolus IV, in the ER if possible, if not in the ICU as soon as the patient reaches the ICU. And we start low molecular heparin, single dose per day. At the moment we are using Arextra, Fondonex heparin, and we are giving according to the body weight of the patient. Less than 50 kg, we give 5 milligram subcutaneous once daily, up to 107.5, over 110 milligram subcutaneous OD. So in the same time, we have to start warfarin or the oral anticoagulation. So we start at the same time the oral anticoagulation, and we keep both running for at least 5 days till we reach an R of minimum 2.5 till 3.5. When we reach this, we keep both running for 2 more days together, and then we stop the heparin and we give only oral anticoagulation. This is our regime in our hospital. Now the guidelines for putting a vena cava filter also discrepancy. You never finishing soon. So many guidelines do not advise to put a vena cava filter unless we have a contraindication for giving the patient anticoagulants. Many guidelines advise for thrombolytic treatment. Now many of colleagues will say, why you don't give thrombolytic treatment? We have a pulmonary embolism, blockage of the pulmonary artery with a clot, give thrombolytic treatment. Yes, many studies have shown that there is no advantage giving thrombolytic treatment only in cases with hypotension, with shock, blood pressure less than 90, severe right heart failure, and that means now either I do thrombolytic treatment to try to open the pulmonary artery as soon as possible to save the life of the patient, or I don't. So only in life-threatening conditions we give thrombolytic treatment. So it might be life-saving, as I said. So I will jump this, how it works, goals. Contraindications are clear. if you have a patient with a cerebral hemorrhage in the past 6 months and pregnancy and all these, also there are relative contraindications and absolute contraindications. So again, the anticoagulation, warfarin therapy. So I come to prevention. Prevention medicine. In the pulmonary embolism, as you now see, it's a very difficult disease, very difficult to diagnose, very difficult to treat, and it's easier to prevent pulmonary embolism than to treat it or to diagnose it. So please, prevention is very important. Patient has to be active. Patient has to come out from his bed as soon as possible after the surgery. We have to use stocking, training. We have to give heparin, anticoagulant drugs as perioperative. When the patient is lying down for 2 days after the surgery, he should get something. Still, we have in our facility some of our orthopedic surgeons, sorry to say that they don't give heparin postoperatively even for surgeries, for knee replacement, for example, because they are afraid there will be a bleeding. So he preferred to lose the patient with a pulmonary embolism than to get a little bit swelling in the knee. So we have to be strict in our hospital. We have to refuse doing cases unless the orthopedic surgeon agrees to do this. It's really high risk for them. We have to develop a policy where we can use this. The prognosis depends according to the pulmonary embolism, according to the treatment. When I diagnose the patient, did I treat right? The prognosis is huge. From nothing, patient goes home after 1 week, or patient dies in the first 2 hours. So the conclusion, prevention is very important. This is watch and go in the ward is unacceptable anymore, and doing the proper diagnosis is very important. Thank you.
Thank you, Dr. Hussain, for such a wonderful lecture. Am I audible? Hello?
Yes, now.
For a wonderful lecture on pulmonary embolism. You know, this is one condition which, whether you are an anesthetist or a physician or a surgeon, you don't like it. You had decided that you will shift the patient next day morning, and you suddenly get a call, the patient had arrested. And probably somewhere when you review 100 files, you will find in 50 of them, you were responsible. You did not take care of the prophylactic in that particular patient, because patient was post-surgery, and although 4 or 5 days have passed, you still did not start the prophylactic. And I think it is one of the commonest cause, I feel, whether it is intensive care or a post-operative, commonest cause of a sudden death or a sudden acute breathlessness in the ICU or in the post-operative, or a person who is not being mobilized. What I find, you know, I am an intensivist, what I find is there is a lot of reluctance on the surgeon who's done a knee replacement. He'll not allow, some of the surgeon will not allow to start prophylactic, the heparin for few days, because for the fear of a little bleed in the joint. And every surgeon has a different, and there are clear-cut guidelines before and after for the knee replacement, hip replacement, which is the highest risk for the pulmonary embolism. And I think one of the other things which in the intensive care, in the post-operative, when you take a round, it is important to think of mobilization. Because it not only in a patient who is admitted with some prolonged illness, mobilization should be a part of sodium, potassium, oxygen, and mobilization. That's my part for last many years. You'll be surprised. Mobilization is a mobilization. Sometimes even a ventilated patient on an ambu bag we mobilize, because it not only prevents all this, it also prevents critical illness neuropathy in a patient who is very sick. Then as far as the diagnosis is concerned, we all get an X-ray chest, as Dr. Azim said, the X-ray chest and ECG. They have a non-specific findings, but I tell you, according to the PIOPED study, the X-ray chest is abnormal in almost 80 to 90%. Some abnormality, plate-like atelectasis, effusion. In very few patients you will get a Westermarck sign or an infarct. But an ECG, if you get a new onset RBB, you know, in a patient, but they will have a non-specific STT changes. They do not give you a diagnosis, but they increase your suspicion that probably this person could have pulmonary embolism, and you are more convinced to investigate that patient. And if is a patient is a pulmonary embolism, one investigation which you must get it, if patient can be shifted to the CT room, please get a CT pulmonary angio, or if it's not available, at least see CT. That's number one investigation for every patient, rather than wasting time on ultrasound. And if you have a very high suspicion, you get that first. Now suppose a patient is hypotensive and he's on a very high vasopressor. He cannot be shifted to the CT room. Now, of course, as he said, that any patient, when you suspect pulmonary embolism, the first knee-jerk reaction is give injection heparin, whether you give a Clexane or whatever. Even the low molecular weights are as good, unless you are planning to give a thrombolytic therapy, where you will prefer unfractionated. So any one of them should be immediately one. You may decide X-ray, chest, ECG, everything, but get that injection if there is no contraindication. That's the first thing. Suppose a CT angio cannot be done, I think 2D echo and the ultrasound of the deep veins. If in a hypotensive patient your echo is not showing anything, it is not pulmonary embolism. In a hypotensive patient, there will definitely be some signs on the 2D echo. It could be a right ventricular enlargement, there could be area of hypokinesia. If you don't find anything on them in that patient, probably pulmonary embolism is not a reason of hypertension, it is something else in that patient. But if you find either in 2D echo or in the compression ultrasound of the leg, if it gives you diagnosis, you do not require anything. You can start the treatment in that a BD dose or Arixtra, as he said, as a single dose. Then VQ scan, the problem is the VQ scan is not available. He's very lucky that he has. VQ scan is not available in many of the centers. And normally we hardly do in our centers the VQ scan. And the one indication which used to be that a pregnant lady you should do a VQ scan, but the recent studies show the CT angio is better than even for the fetus than the VQ scan. Then as far as the fluids are concerned, all these patients you can give about 500 to 1 liter, but after that without monitoring you should not give, because it will stretch the myocardium and ischemia might increase, and hypotensive patient may further worsen the hypotension. And of course if there is an indication for thrombolytic, you must give it, and in my book there are 3 indications. One is if there is no contraindication, patient is hemodynamically unstable, class 1 indication. The other is 2D echo is showing the signs of pulmonary embolism, and the BNP and TROP-I are very highly raised. That's not a class 1A, but that's an indication. The third indication, where I have used twice, is during CPR. You know, there is a patient who was doing very well and suddenly get a pulmonary embolism, and you are called and you do massage, and at the same time if you have an echo available, I think after 10 years everyone will have to learn a basic ultrasound and echo. And if you find right heart is enlarged, I think that it is recommended in the ACLS guidelines to give the thrombolytic therapy. And we've saved one patient like this by giving the thrombolytic during CPR. And that's my take on this. If there's any question, I think Dr. Hazim would be very happy to answer them.
I think you have summarized it so well, Rajesh, that I don't think anybody will have any questions. But if anybody, yeah, there will be question.
Thank you. Sir, how many days anti-thrombotic therapy should be continued?
So
anticoagulant.
Anticoagulant,
yes,
sorry.
I had no time to go through. It was mentioned very short. We advising 3 months now. After 3 months, re-evaluate the case, re-evaluate the condition of the patients. Do he need more or not? And according to that, either extend for 3 more months. In critically patients, we advise for lifelong then. But there are very rare cases where you advise to give anticoagulant for lifelong. Most of the cases, 3 months only. After 3 months, re-evaluate and most probably stop this.
Okay, which drug are you are frequently using to switch over from injectable to oral?
Yes, 5 days as I said. We give from the first day Arixtra, subcutaneous, and we start most probably second day with oral anticoagulant. Now we have the new oral anti-Xarelto. We use till now still warfarin. We give warfarin with Arixtra for 5 days until we reach INR more than 2.5.
Is it advisable to get the admit patient for 3 months?
Not admit the patient. You have to give warfarin at home then. You discharge
Okay,
as soon as the patient is stable, clinically, you shift to the ward 2-3 days, everything is fine, you send home. But he has to keep controlling his anticoagulation.
Okay, sir. Thank you.
Thanks very much. I think what we'll do is, one of the greatest advantage of this group is that you can actually continue the discussions actually on the group.
Sir,
we don't actually finish the lectures here. Yes, you heard the lectures. You have any doubt, Dr. Daji is there on the group. Okay, you can actually direct questions to him anytime you like. Okay, you can open up the discussion anytime you like. Okay, and get everything clarified. Okay, I think we're going to be short of time, Yuvraj. Okay, so what we'll do, we'll go on to the next lecture. Thank you very much, Dr. Daji. Excellent lecture. Okay, next lecture is on antibiotics, and that'll be Navin will be giving this lecture, use and abuse of antibiotics in the intensive care. I'm sure you're going to enjoy this lecture.
Good morning, everyone, and I feel really privileged and honored to be in your company today. And straight on to business: antibiotics in intensive care. Topic very topical these days. So my job is to keep you focused for the next 20 odd minutes, and we're going to cover like how how antibiotics came into modern medicine, and then how things have progressed over the last 50 odd years plus. And where are we at this moment in time, and what future holds. I'll leave the future bit to you and to your judgment. Okay? So it was in 1928, the gentleman on the left, Alexander Fleming, he actually discovered a mold called the penicillin, the blood mold, and it was accidentally contaminating its blood agar growing golden staph, the Staph aureus, and he found that that was inhibiting the growth of the bacteria in those blood agar plates. So it is like a accidental discovery of a trained mind, which is called as a serendipity. But it took almost 10 years plus. In the middle of Second World War, the two gentlemen, Chain and Florey, they were responsible for the mass production of penicillin and the real introduction of the drug in modern medicine, which kind of was a game changer in those days, because most people who got injured were having skin contaminations, and it did show a significant improvement in survival. But even in the early days itself, Fleming discovered that this had no effect on cover for gram-negative bacteria, and there was a hot pursuit to find out what we can do to contain the growth of those bacteria. So unlike the serendipity of 1920s, it is like a hot pursuit. We knew that we wanted to treat all these patients who get gram-negative bacilli, and the way forward was to find out drugs which could effectively contain them. So this is actually the antibiotic timeline, where we see that even before penicillin, we had antimicrobials in the form of sulfonamides, and then there was a flurry of discoveries in the 40s, and there were the beta-lactams and things. And the first group of aminoglycoside, which is the first class of drugs which had effect on gram-negative bacilli, came in mid-1940s. And then until 1960s, late 1960s, there was a interest in developing antibiotics. At the same time, it is not surprising to see that the resistance were also being documented for all these drugs we were developing in a few years since they were discovered or invented. So the bacteria were always playing their game too. Interestingly, in 1970s, the interest in developing newer antibiotics went away. This is not just because we were too good in treating patients with infections with antibiotics. There were a lot of other things which happened in the 1970s. The general health of the patients were improving because surgeons were better at aseptic techniques. The safety from anesthesia improved. We were doing more elective cases than all contaminated wounds. Vaccinations took on. We started understanding a bit more how the bacteria and things work, decolonization, a lot of things. And also, from an investor point of view, with regard to drug development, they also realized that, antibiotics people use for 5 to 10 days, and it's not being used. So, and it makes more sense for you to invest in things like diabetic medications or antihypertensive where patients are literally hooked onto them. So for a long period, like a good 30 years, there was no more future development of drugs, and we can see that things started catching up because we lost the game towards 2000s, and as more and more resistant bugs came, we were running out of options. Now, this is how the a schematic diagram of how this development of resistance happens. So the thing in the corner, this is a human microbiome where you can see that we all have bacteria on our cells, inside and outside. Some of them are pathogenic, most of them are not. They're just commensals, and there are drug-resistant bacteria in nature itself. So what happens is when we give antibiotics, the number of resistant bugs is going to be selectively reproducing. Then there is also contribution from household, industrial waste, and all those things, which also contain antimicrobials. And then you start reaching a situation where the proportion of drug-resistant bugs is much higher. And then there's actually a game changer here. You can see that there is transference of genome in the form of plasmids from the drug-resistant bacteria to the non-resistant ones, and some of them could be pathogenic. And that's where it all catches up on the patients, because you have now bacteria which are virulent and also have drug resistance. And probably we are dealing with more and more patients in this subclass, and that's what makes it very topical these days. And there can be multiple mechanisms by which bacteria can gain resistance. It could be either by preventing the drug entry or by efflux of the drugs. They can change mutation. They can mutate and change the target. So they have an entire battery of ways to deal with antibiotics themselves. And a couple of bacteria and things which I thought I should discuss. One is the golden staph, because it's highly relevant to our clinical practice. And the next is the gram-negative bacilli as a group. So the Staphylococcus aureus gets its name from its appearance in microscopy with gram stains. You find them, they look like a bunch of grapes, blue-colored from the gram staining. And when you grow them on a blood agar plate, they have a golden hue to them, so hence the name aureus. And it's also interesting to note they have a beta-hemolytic effect in the blood agar plate. They bring about true hemolysis. And what makes it very relevant to our clinical practice is because they're highly virulent, even though it's carrier in like 30% of the patients, or in normal population, when there's a chance to infect, they have high pathogenicity because they've got a large amount of virulent factors attached to them. They have enzyme systems which can literally break your tissue barriers, like using hyaluronidase or coagulase, and even lipid barriers using the lipase. And some of these staph can also produce toxins, exotoxins like the superantigens causing toxic shock syndromes, or the exfoliative toxins of scalexins. Even we get necrotizing pneumonias. We start seeing them more often these days from the PVL mutants. And the other important thing is that there is a clinical relevance beyond these primary infections. That's when we have more and more resistant virulent staph in the community, the general safety of surgery itself gets compromised. This is because it's a common thing on human skin, and then you breach the skin in surgery, so your risk of infection increases exponentially. So same thing with the ability of them to bind onto prosthetic devices and also cause heart valve infections or things like infective endocarditis. Resistance mechanism, broadly two types. One is they can inhibit the enzyme. They produce the inhibiting enzyme beta-lactamases and break down the beta-lactam ring, which is the common ring for penicillins, even your cephalosporins, all the way up to carbapenems. Fortunately, most beta-lactamases do not attack the carbapenem rings. The other smart way they try to decrease the efficacy of antibiotics is by altering the binding protein itself. That's where the MRSA comes from. So when you've got a patient with MRSA, then there's no point in trying beta-lactams or even other subclass of drugs like your macrolides and things, or fluoroquinolones for that matter. You have to use things which act independent of the penicillin binding protein. So we're talking about things like, are they using vancomycin, or more advanced things like linezolid or daptomycin or tigecyclines. And of late, there's an increasing number of reports about vancomycin resistance or intermediate sensitivities to vancomycin in Staph aureus. So two different mechanisms actually. One is the simplest way the bacteria can do this is by increasing the number of target binding sites. So you're going to overwhelm the drug itself. So a fair few bacteria survive and they will eventually cause problems. When it comes to resistance to vancomycin in staph, they actually change the binding site itself. Now, this is actually a case report published in New England Journal. Actually, it's from South America. I find it's quite interesting. And you can see the patient turned up in November 2011 with a soft tissue, skin and soft tissue infection, and was treated with conventional treatment with clindamycin, Keflex. It didn't go away. Then he started getting bloodstream infection. They brought in the car with vancomycin, and then PIT-TAS. Eventually, what happens is that there is a lot of selection pressure, and the patient's bowel flora itself changes. You know, the enterococci, there is always a subset of enterococci, normally in our flora, which could have resistance to vancomycin. So you've super selected this thing, and a nightmare happens where the enterococcus has transferred the gene of vancomycin resistant to Staphylococcus aureus, and the patients get a vancomycin intermediate sensitivity in staph. And this is a nightmare for all microbiologists. You know, when you start getting more and more vancomycin resistant genes being transferred from enterococcus to staph, elective surgery is going to be increasingly risky because you're going to run out of options. Now, when it comes to the timeline of drug resistance in Staphylococcus aureus, we can see that the first resistance to penicillins were reported. The very next year, it was used as medical therapy in humans. So it's always an arms race going on. You can't say that you have developed a drug and we're safe. They are going to catch up very soon. And subsequently, we can see that they had introduced vancomycin. There was a time lag because it's not because vancomycin was a much more potent drug. Actually, it's a much more weaker drug when compared to the other beta-lactam. But the use of vancomycin was much less in 1950s and 60s and late into the 1990s. Not because one was it is expensive, and next thing was that it had a huge side effect profile, so it is not used, or rather abused in a large way like other beta-lactams. So we had a window of opportunity where vancomycin resistance was not prevalent, but now we use it much more liberally, and we can see it emerging as a major problem. And subsequent to that, we have introduced a fair few drugs like the linezolid or the daptomycin and tigecyclines. Except tigecyclines, most of the other drugs, resistance have definitely been reported. I'm sure there is tigecycline resistance somewhere around. It's just a case that we haven't found it or documented it. And the next bit is on gram-negative bacilli and their resistant mechanism. Basically, they are very notorious with regard to transferring resistant genome by means of plasmid-mediated transfers or by conjugation of the bacteria. That's why some microbiologists call them, they're very promiscuous. Like if you have a resistant genome in E. coli, you find a few days later that a patient who had Klebsiella infection also has the same class of antibiotic resistance. That's why we are always wary about gram-negative bacilli, and I understand in the subcontinent especially, this is a nightmare. Like probably because of our much more liberal use of antibiotics, we have kind of created a situation, or rather bacteria has outwitted us, and we see that there is a lot of emergence with the metal or beta-lactamases, which kind of popularly, initially at least in some states, called as the NDM1s. And what are the treatment options now? We go back to drugs which we kind of condemned in 1970s, telling that are too toxic for human use. So we're going back to polymyxins and colistin. They're not like new drugs of discovery. They were abandoned by science of those days, telling that too risky to be used. But that's all what we have now, not because they're any potent, just because we didn't use them like the way we were using them in the past. So nothing very special about these drugs, except that they're too toxic and they use less. But if you use them liberally, we are going to have more and more patients coming with antibiotic resistant to polymyxins and colistins. Now, this is an interesting group of gram-negative bacilli, the escapem group. Why they are important is that they will trick the clinician unless you're aware of them. So you should be familiar with all these ones, the Enterobacter, Serratia, Citrobacter, and the rest in the group, because they have actually a chromosome-mediated, not plasmid-mediated. They can induce resistance during the time of treatment. So you may get a microbiology report telling that they are sensitive to ceftriaxone and something, and you start treatment, in 48 hours' time, the bacteria will find, oh, well, I have to use my reserve armamentarium. It starts encoding the beta-lactamases, and the treatment inevitably fails. So when you see any patient's microbiology reports coming that it's having an escapam infection, you start treating with aminoglycosides and carbapenems rather than forcing an inducible resistance there. And now, this leads to the big question. Why do we get antibiotic resistance? Is it just something of our own creation, or is it something beyond that? Probably it's a combination of both. There's no doubt we are in an evolutionary arms race. The paleobiologists think that beta-lactamases are like 1 billion years, like 1,000 million years old. So they've been here long before, the first mammals ever reached onto the surface of land itself. So they've been there for a very long time. But the big mistake we made was in the 1970s, because we thought that it's all very safe. We've stopped this whole problem. We were in the honeymoon phase, and now we realize it's all over. And we did accelerate the whole process by indiscriminately using antibiotics. And worse things, everyone talks about using antibiotics, but worst things you can do is you underdose, or you use underdose and prolonged courses of antibiotics. This will lead on to more and more subgroups of bacteria which would overpopulate with drug resistance. And are we prepared? Not very much. You can see from that timeline of antibiotics that there's not much in the pipeline. And it doesn't mean that everyone is going to die in huge numbers because there is antibiotic resistance. No, that's not the case. That's just media scaremongering. What is really going to happen is elective surgery becomes increasingly risky, and patients who are more vulnerable and who have been surviving reasonably okay, like the transplant recipients and all, they will suffer the most, because they are the patients who will need antibiotics many times in their lifetime, and their life expectancy will be significantly compromised. The overall mortality would certainly increase, and life expectancy is likely to fall unless we have an opportunity to develop more drugs in a very short time, and we can at least buy time to get on this problem of antibiotic resistance. Now, we are kind of in a damage control mode now. Some of the suggested solutions are we rationalize antibiotic use. Rationalizing is a very generously used term. I don't know what exactly it means in this context. We'll try to probably look at it, how rational is irrational in this world. And then more important strategies are like emphasizing source control. If there is pus, antibiotics is not the option. Draining the pus is the first thing. So your surgeons may beg to differ, but they need to definitely get the pus out and contain collections. You stop antibiotics, they're going to come back with more resistance. So there's no easy way out. Sometimes you will have to accept the risk of surgery and proceed, rather than just telling, well, the pus in the belly is going to go away with antibiotics. Same thing with cycling of antibiotic. Not much published evidence to say this something helps, but the jury is still out. Nobody knows whether it really works. In principle, what it means is that a patient comes with pneumonia, the first person gets fluoroquinolone, and then the next one gets a combination of beta-lactam with macrolide, and then you probably go back to a combination of tetracycline with your penicillins. So you cycle for the same disease process with the same likely pathogens with different classes, so that they don't get a chance to emerge resistant. But again, it's not proven on randomized controlled trials or even in limited trials that it really works. Then surveillance cultures is pretty important. We'll be going through that in fair detail in subsequent slide. Why this is important is that this will give you the first-hand information about what antibiotic to start when you have someone sick turn up at your door. Unless you know what box you have to treat, there's no way around it. So guidelines are a guide. They will not substitute your local microbiology surveillance cultures. Local policies and guidelines, they're very, very important. Antibiotic stewardship, that is about someone standing, looking over your shoulder and telling, are you doing the right thing? And gentle reminders constantly. And a very important issue, acknowledging the interests of the community, not just the individual. I understand that as doctors, our prime intention is to look after the patient at the end of the bedside, but we also have a moral responsibility to look after the interests of the community. Otherwise, as a population itself, we will run out of resources. Now, when you think outside the box, emphasis on disinfective measures, you can't underestimate things like hand washing, and doctors are very, very bad at this. It's easy to train nurses, medical students, and as you move up your ladder in the hierarchy ladder, your compliance with hand washing starts falling. The worst culprits are obviously the consultants, no doubt. And if you're a surgeon, you believe it only when you're scrubbed up for theater. When you're doing a ward round, you never do it. So constant reminders, there's no easy way out. Next is isolation and decolonization. may not be practical in a lot of situations, but there's no way around it. We will have to think about it more seriously. It is money well spent. Vaccinations, they can prevent a lot of diseases, and they would probably decrease the antibiotic use. We may have to think on alternate strategies like pooled sera or immunoglobulins. Published evidence very limited, but I'm sure over a period of time, these things, just like polymyxins, may make it come back. Hyperbaric oxygenation, no major trials to support its use, may be worth considering in the occasional patient. Probiotics, they keep coming and going. Again, the jury is still out. Fecal transplant, it's found some increasing use over the last few days. Not because it's very pleasant, because just because we're running out of resources to treat Clostridium difficile. And you know how most people get Clostridium difficile? They go to your general practitioner, or they self-medicate with amoxicillin or whatever they get their hands on, and Clostridium, which is usually in your bowel flora, they overpopulate, and they reach a critical threshold from where it becomes a nightmare to get rid of it. And most patients, they're not going to be accepting fecal transplant as even second-line therapy. This is like when they get desperate, they tell, yes, I'm happy to even taste that bit. Because, yes. So things are getting so desperate. And I can say that we did like 4 fecal transplants in the last 3 months. And there's not much of an option. And patients themselves volunteer telling that, yes, I can't put up with this diarrhea anymore. And the other thing is considering minimizing, hospitals, we all think it's safe places, but that's not true. The longer you stay in hospital, you're likely to get into problems. So if you're just there for antibiotics and things, you may have to have a kind of domiciliary service like hospital in the home. If it's just one shot of antibiotics and things, they can pretty much send home, a nurse can go and deliver things. So you have to think outside the box to address the problem of antibiotics. How are we going to use it? Now, mind me, this is one of your mnemonics for rationalizing the antibiotic use. And it just expands to something like microbiology should guide your antibiotic use. All your indications should be evidence-based. You try to use the narrow spectrum of antibiotics. Dosage should be appropriate to the size and type of infection, minimal duration, and whenever possible, you're going to use monotherapy. So what does it mean? In summary, indications for empirical broad-spectrum antibiotics should be evidence-based. Ensuring monotherapy on narrow spectrum based on your microbiology, and de-escalate whenever possible. That sounds too easy, and well, there's a catch. That's going to be too good to be true. So it does fail. If it is that easy, I'm sure most people would embrace very happily, and we would all be doing the same thing. But the practical issues are, you have to start treating your sick patients earlier than late. There's no equipoise there. Delay antibiotics translate to increased mortality. But cultures and antibiograms, they're going to take a fair bit of time. You may get it, if you delay it long enough, you'll get it like a post-mortem report then. So you have to start treating, and there's a delay anywhere between 1 to 3 days, depending on where you are and what kind of facilities you have. And what does the International Surviving Sepsis Campaign say about the whole thing? They say empirical antimicrobials within first hour after recognition of severe septic shock against all likely pathogens, including using one or more drugs. Okay? This is probably the most abused statement in the entire guideline. They clearly mention that this is for severe sepsis or septic shock. It's not for everyone turns up at your door with fever. So you do your surveillance cultures on your intubated patient, says that there's Acinetobacter colonization. You don't do any antibiotics at the time, fair enough. And then the patient spikes a fever. There's no compromising of their ventilation or oxygenation. They're not in septic shock. What's the knee-jerk reaction? Now they all go on polymyxins. So you must have fair amount of clinical acumen. You should be able to decide on the bedside. Your guidelines is not going to replace your clinical judgment when you have to when you have to optimally use your resources. Now, are these guidelines really helpful? This is from New England Journal, published a month ago, How to Treat Community-Acquired Pneumonia, one of the most common diseases we encounter in our practice. So, if a patient, known emphysematous patient, turns up to the hospital with a history of flu, and you do a chest X-ray and you see a patch, this is what the guidelines say. You need to treat for flu. You put them on oseltamivir, fair enough. Then, you need to cover for the community bugs. So you have to have either a combination of a beta-lactam with something for an atypical CAR like azithromycin or amoxiflox. Because these patients, the risk of staphylococcus infections is relatively high because you've got already a disruption of your mucosal epithelium from the viral infection. You need to put them either on vancomycin or linezolid covering for your MRSA. And then lots of these patients with COPD have Pseudomonas colonization you need to treat also. So you're talking about, based on guidelines, a patient should get 5 antimicrobials. So you can see that, are they really helpful? They're making your life more difficult at times. So what do? We may probably stick onto the guidelines. You try to de-escalate. Is there much of published evidence? Recent trial in intensive care medicine. Not really. This is a French trial involving 9 French ICU, 120 patients. Median de-escalation days 3. They find that even when they use the broad cover for a short period of time, there was an increased risk of superinfection, and there was an increased tend to having increased resistance. So you have to, there's no substitute for clinical judgment. If you do not have a high prevalence of MRSA in your unit, you should not be using an MRSA cover. ATS the Americans can say whatever they want. We don't stick on it, because if you do not have a prevalence, that's it. And same with the decolonization for MRSA. You know, we all like to say that we make your life easier and simpler, but published evidence say that universal decolonization is effective, but it comes with a catch. You should be very vigilant for emerging resistant bugs. So you use decolonization very liberally. Like, that's why a lot of people do not embrace your selective digestive decontamination. You embrace it very liberally, the bacteria will eventually outwit you. So I find this trial very interesting. There's a trial on, from Southeast Asia called the ANSOP. This is the Asian Network for Surveillance on Resistant Bugs. And they did this prospective study over 8 years on strep pneumonia, the non-meningococcal isolates. And there are 2 graphs. The first one shows how vaccination, this bit of the graph shows, for the vaccinated serotypes of strep pneumonia, there was a change in the prevalence. You know, this bit of the 19F is not very much covered on the vaccine. That's why there's an increase over the last 8 years. But whereas the other ones, the profiling has changed. And those part of the serotype which is not being covered, their numbers actually increase. So even things which happen around you, like vaccination coverage, will affect your antibiograms and the kind of pathogens you're dealing with. Now, here you see that the MIC is more than 4, only in 4%. So most of the patients, they still remain sensitive to penicillin, which is very, very interesting. And I don't know how many of you really use penicillins these days. So 1 in 20 to me appears like it's a reasonable starting point. If there is treatment failure in 24 hours, you can still go back and try. So we believe in this strategy. You should know your enemy and you should have a targeted attack rather than, so every hospital or every hospital group should have their own antibiogram. It's not too hard. You send your most patients surveillance cultures, and if you can't send it for your poor patients, fair enough, but there will be every now and then patients who would be able to afford it, and you develop it, you collate it, and you know what to start. What is your starting thing? And it's not that what happens in Europe or in other parts of the world is going to give you an answer to what you have to deal with. So coming close to the end of the talk, the dosage and duration, they are site-specific. You should always look for the clearance. It's not that everyone in sepsis has decreased clearance. It speaks for itself when you're on kidney and liver failure. But in early sepsis, you've got a higher clearance. So do not cut back on the dosing. Underdosing is more dangerous than just the broad-spectrum cover. And we did briefly mention about this, antimicrobial stewardship. Every hospital should try at least to have some form of stewardship. If you may be electronic, it may be on paper, or it could be even gentle reminders, or even when you do a bedside ward round, someone say, does this patient really need all these antibiotics? Do we think this patient has MRSA? Does vancomycin need to go for another couple of days? Just stop it. So the whole principle is that someone looking over your shoulder and just reminding you, not like in a harsh way. They could just say, oh, well, do we really need this? It could be even your resident. You can allot someone on your ward to say every day someone should remind whether the dose and duration, everything is being done appropriately. Is it based on our local guidelines or is it based on international guidelines, and you sign it off. So in summary, the take-home message is that it's our responsibility to ensure that we use the right drug for the right bug at the right dose for the right duration through the right route. Thank you very much.
Thank you, Naveen. I think he's really covered the antibiotic use and the current problems. I think what everyone is scared of, like, I liked his sentence, acknowledge the interests of the community, not your patient. And that's a problem. Every physician is only bothered about his patient. He would like to give 3-4 antibiotics, try to cover, and even if the culture and sensitivity result is available, which shows clearly there is an Acinetobacter, he would not stop the other drugs. And the other problem is they continue very long. There are clear-cut guidelines for how long you should give. Because there is some shadow persisting in the chest diagram doesn't mean that you have to continue the drugs indefinitely. If it's a pneumonia, not maximum more than 7 days or 8 days, unless it is a non-fermenter like Acinetobacter and the Pseudomonas. The common problem which I think most of you must be facing, these bacteria we've never heard of. In last about 5-7 years, the MDR Acinetobacter, MDR Pseudomonas, in certain places it could be MRSA or Klebsiella. They are really a problem. And as he rightly said that you have to be appropriate. You need to talk to your microbiologist. I think what I have realized over the years is that if you're working in a hospital, talk to a microbiologist. He'll give you that this is the organism which we are growing nowadays and this is the sensitivity. So it will help you to be appropriate, because by the time you get a culture report, it's late for the patient. And repeatedly with your patients, particularly in a difficult patient, you must discuss with a microbiologist. And I think it is also important, try not to use these drugs like polymyxins unless they are really indicated. Because I predict that after a few years we will have Acinetobacter also resistant to polymyxins, and we'll be left with hardly any drugs, and we'll go back to drugs like chloramphenicol and TG-cycline or tetracycline, which are really not effective. In one of his slides, which I think is absolutely correct, the most affected would be the surgical specialty, because the infection will be rampant, and if you are not able to treat them, mortality would be higher, and then there will be a problem. So I think all of us, it is a joint responsibility that it is important to use antibiotic, but I think it is even more important when not to use antibiotic. Thank you. I think he took a very, very good lecture.
It was a fantastic lecture, Naveen. I think it was very, very enlightening, I think. Does anyone have any question to ask? One? Okay. Right.
Thank you, Dr. Naveen. It was a very nice lecture, very enlightening. The only point where I'm stuck up is that as anesthesiologists, both in ICU and OT, we are using IV fluids. What is your opinion about use of IV fluids and antibiotics together in view of hemodilution of antibiotics? Current guidelines.
So I don't think it actually makes a difference. What we're interested is depending on the class of antibiotics, whether you reach your peak levels or you get the area under the curve and things. So you're talking about surgical prophylaxis, which is only for 24 hours. So the reason why you dilute and give is that at induction or pre-induction, the last thing you want is someone to get an anaphylactic shock. So if you give a small amount, you still get the similar reactions or the rash, and then things deteriorating, you'll be able to pick it up and you can stop it. Whereas if you give the big dose, in some patients, there will be a catastrophic event. So that's the only rationale. The peak levels will be attained if the total loading dose is not altered.
No, I'm sorry.
Yeah.
I was not asking about how to dilute the antibiotic and give it in the IV route. I am asking the overall how much fluid we are giving. Suppose we have taken the patient in the OT and given central neuroaxial blockade and given a dose of antibiotics, say 1.5 grams of whatever.
It makes no difference to whether you're giving with 1 liter of with 1 liter of fluids or 2 liters of fluids. It's not going to make any difference to your antibiotics. You will attain the peak plasma concentration.
There are few papers which are saying that you have to keep the patients a little towards dehydrated side for the antibiotics to work. We'll discuss it on the group.
Yeah, we can actually. I think it'll be a good question to discuss on the Facebook. Okay.
Good one.
Yeah. Very nice. Thank you, Naveen. That was fantastic. Next lecture is from Piyush. Okay, he's going to keep it very entertaining. He's an entertaining guy, you know him. So, okay, it is about, so we moved from P, which is obviously a major cause of death. Infection is a major cause of death. Then the other thing which kills patient is obviously is ARDS. Okay, lungs, not being able to ventilate. Okay, it is bad. So Piyush is going to talk about the ventilatory strategies in these cases. Okay, the last thing before I hand over to Piyush, can I ask people to actually put your mobile phones on silent, please? It is very, very irritating to hear a mobile phone going up on the back when you're actually hearing something. So please, everybody, put your mobile phones on silent. Thanks, Piyush. He's putting himself.
I should do the first one. Good morning. Good morning, Chairman. Today's topic is don't make things worse by ventilatory setting by you and how to ventilate ARDS. My name is Piyush Malik. I work as a consultant ICU in UAE and anesthesia. So, now complications due to ventilations, pages, lots of papers. So there are various types of injuries directly related to ventilators like barotrauma, biotrauma, atelector trauma, volute trauma, ventilator-associated pneumonia, oxygen-related. Probably now we are understanding more and more that hyperoxia is bad, tracheal bronchial issues. So basically, you know, all this trauma causes complications. Now, what do we do to prevent VAP sort of things? So we apply a ventilatory bundle, 45-degree head up, daily interrupts on sedations, acid prophylaxis, DVT prophylaxis, oral care, subglottic suctions, selective digestive tract decontaminations, came from Amsterdam mostly, and so basically, and hand hygiene. So this is directly, you know, the VAP, although it's not a complication of ventilation, direct ventilation, it's a disease of this part, okay? But patient is on ventilator, and if you put on ventilator, basically it's a upper airway disease. It's not related to ventilation directly. Now, have you ever think that what does the patient feels? If you go to a dental surgeon, he puts that white one, that wooden stick, it's quite painful, you know. The first thing when we get a tube or a patient gets a tube, it's the pain. Pain should be treated first, post-intubation. If you taken care of pain well, you will give your patient sedation less. Less sedation, less time on ventilations, early assessment of weaning, and all those sorts. I mean, you don't, I mean, if you give a good painkiller, then you don't land up giving 10 milligram of Dormicum, which will take a hell lot of time. So, now ventilation lecture. In my life, whenever I went to a ventilation lecture, I heard 2 or 3 new modes, around 5 or 10 equations. I ended up with more confusions. And in the room, I felt that I understood everything. And outside the room, after 2 hours, what was that equation? It's not there. So this is what happens. Lectures, conference, you know, so what I did, I simplified things. My lectures do not have any equation or any confusion. All right. So this is a viral picture. You go to internet, if you study ventilation, this picture will be there everywhere. This is a rat lung. This one is normal, just intubated, no painkillers. This one is 5 minutes after ventilation, and 45 centimeter was the pressure the ventilator was giving. This pressure was a peak pressure. We are not talking about plateau pressure. And this one is just 20 minutes. Now rat lung, after 5 minutes you can see a hemorrhagic spots here on left upper lobe. So within 5 minutes this can happen, okay? And it's 20 minutes, all hemorrhagic. He was a rat. So, what I am going to tell you today, I have been telling it in the forum since last 3 years, and some people are following it, and hopefully I'm getting a good feedback. This is what I do. There are two kinds of lung exist in this world. You divide the lung to two parts, and two kinds. You are ventilating either one or two. The first one is a lung injury type. Your patient had ARDS, patient had some kind of lung infection. It is a lung injury type of lung. The other one is the asthmatic COPD group, emphysema group. So you divide it. You'll ask me, I'm anesthetizing a patient who has a healthy lung. He came for hernia. You just keep them, for my request, just keep them in the lung injury type of lung. All right? Head injury guy, patients coming. It's a healthy lung. So we have only two kinds of lung. So you just need two strategies to remember. So not knowing to ventilate which type of lung and how to ventilate, you produce ultimately a lung injury. I mean, a healthy lung, you don't know how to ventilate properly, so you produce a lung injury. This is what coming to anesthesia. Look at this paper, 2010. If you ventilate a normal, healthy lung with your conventional setting, then you produce lung injury. Say it be 1 hour, say it be 2 hours. It includes anesthesia. More and more anesthesia machine ventilators, you will see started to come in PCV, all the modes. Okay? So, healthy lung can be injured by your wrong ventilatory setting. And how many of us do it wrongly, you will see now. So only two strategies I am saying. Modes. Tons of modes available. I use all the modes all the time. All right? For sake of understanding your patient's lung, you just put them on assist control volume mode to start with. You understand this mode. By the way, this is the mode where the ARDS net did the study. There is no other mode which is better than this or that. I don't say pressure control is not better. To sake of understanding, you can put on any mode. But just to start understanding your lung, put the patient on maybe for 1 hour, maybe for 5 minutes. You understand your lung. Then you go to any mode. All right. Two types of lung, two strategies. What I am saying is, this is ARDS and this is obstructive. And only you have to remember 4 knobs. Ventilation is finished. All right? So what are those 4 knobs? If you divide, there are hundreds of buttons now. So if you divide your ventilatory panels into these 4 parts, things will be very easy. And you should be knowing which is for what. Okay? Now, tidal volume is for lung protection. You ventilate a patient with a tidal volume such and such to protect the lung. And let us see what we are doing. You will be surprised to hear that what we are doing. All right? Now, respiratory rate is for ventilation. I will be repeating multiple times so that at the end of the lecture you might stuck into your head. Inspiratory flow rate is for patient comfort. PEEP and FiO2 has only one purpose. They have many purposes, but their main function is for oxygenation. So, our topic starts now, lung injury or ARDS type of ventilation. This is ARDS lung, which already started. Tomorrow it will be more, and the area available for ventilation. We all know this, that the healthy alveoli are less. If you give a same ventilation, the pressure will go high and lung. So basically, Italians tell us that is a baby lung is developing. The adult lung it's called bambino lung. All right. So what to set? What to set? Now, this is the most important sentence of my lecture. Calculate the predicted body weight. Let us see who qualifies for 500 tidal volume. I am saying, you go to any ICU, you will find 500 tidal volume, 12 breaths per minute. It's the usual setting. Say it be America, say it be London, wherever. This is the usual setting. Okay? So select your ventilatory mode to assist control. That's what for the time being we are saying. Achieve a tidal volume 6 to 8 ml. 6 ml is preferable. Respiratory rate to maintain a eucapnia. On ARDS net, this is the copy of ARDS net. They say up to 35 breaths per minute, you can ventilate. And saturation aim never, never, ever 100%. It is always 88 to 90%. You never know. We are understanding the hyperoxia is equally bad like hypercarbia in the past, for the head injury even. I mean, this came from the therapeutic hypothermia trials. Those patients came from 300 or PO2 or more, they died more. So increase PEEP up to, how many people are ventilating with the 24 PEEP? I don't say do that, but this is what they did, all right? So, and pH goal of this much. Now, who qualifies for 500 tidal volume in this room? Except V. Mohan, nobody qualifies. My tidal volume with a 5.10, 5 feet 10 inches, I am 433 ml. If you ventilate me at 450 ml, my lung is not protected. Okay? So, if you are ventilating anybody with 500 tidal volume, probably his height is 6.3 or you are doing it wrong. Okay? So, this is the formula, 50 plus 2.3, height in inches above 60 inches. And so you have to remember this. Once you do 2 or 3 cases, you will understand. The same thing holds good for your anesthesia ventilator. Let it be for 1 hour, but lung will be protected. You never know what kind of lung he has. All right? So, predicted body weight or ideal body weight is very, very important to know. So, predicted body weight is nothing to do with your weight. It is related to your height. I might be 500 kg or 500 pound or 50 kg. My tidal volume remains the same if my height is the same. Okay, 3 different person, the tidal volume remains the same. Now, all right. So, 4 knobs to remember. As I said, tidal volume is set to protect your lung. Nothing, no other function should be used for tidal volume. So, we said tidal volume for lung protection, we covered it. The only time where you change your tidal volume, you think that your lung is not protected, that equals to plateau pressure of more than 30. All right? So, basically when the plateau pressure, it's not peak pressure like rat lung. So, plateau pressure, which is important, the plateau pressure is the pressure where the alveoli exerts. I mean, alveolar sees that pressure. All right? So we said it is 6 to 8 ml. So, tidal volume is for lung protection. It is not ventilation again. All right? Now, how many of us bothered about inspiratory flow rate? Probably we don't. Okay? Now, inspiratory flow rate is for patient's comfort. I am breathing normally, little bit excited. Probably when I am sleeping, my inspiratory flow rate is around 25 to 30 liters per minute. When I get sick or tired, I'm sick, I'm septic, my requirement goes up to 60 liters. What happens? The ventilator doesn't give. Some ventilators you have to set it. You just have a look. In a sick, those who are getting intubated, they are sick, their respiratory flow requirement is high. If you keep the 420 tidal volume and inspiratory flow rate of 30 liters per minute, you will feel that the air will go slowly and patient will get ventilated very gently. It is not true. See, he will suck air like he'll feel air hunger, he'll buck on the tube, your sister will call you, what you will do? You'll give more sedation. So again, although it is not a very important knob, you go to the patient, see the flow rate, what is his sucking amount and adjust accordingly. So 60 liter is a way to go for sick patients, which can be different for obstructive. We are not going to talk about obstructive. So obstructive, it can go up to 80, 100. So which will rise your peak pressure. Peak pressure means nothing. Don't worry about peak pressure. Peak pressure which keeps on alarming on ventilator doesn't have much value. So it has to be, plateau pressure. Anyway, respiratory rate is for ventilation. So ventilation equal to, very simply, it's CO2 amount or removal. So now how to calculate your respiratory rate? I have put in somebody to a tidal volume of such and such, 420 ml. Now, what happens in the tube, dead space? Now, my basal rate is around 60 ml requirement when I am not intubated. Once intubated, it goes to 120 ml per kg per minute, which amounts to 70 kg guy, which is ideal body weight. It's 840, 8,400 ml requirement of minute volume divided by 500 ml. So its breaths around 17. So if you're putting somebody on protective lung strategy to make him eucapnia, you have to give some more rate. And mind it, ARDS net has allowed you to put a rate up to 35 to make the patient eucapnia. So I set a breath of 18, and I do a BGA. I see it, whether my CO2 is going up or down. So respiratory rate equals to ventilation. And the last dial is actually 2-in-1. PEEP and FiO2 is for oxygenation. Whenever there is, I have seen a ventilator which has one knob, have both PEEP and FiO2 together. I don't say that every ventilator should have it, but I have seen it. Okay? So they have major purpose to solve is the oxygenation. So again, the PEEP scale, I just wanted to remember that there is, the ARDS net has used two scales, lower PEEP scale and higher PEEP scale. You'll be surprised, some of those who are new, they are ventilated in higher PEEP scale when that 30% they have gone up to 14. All right? So here it is a lower PEEP scale. The higher PEEP scale has good oxygenation, although there was no mortality benefit. Don't get afraid of PEEP. The lungs need it to get your oxygen 88 to 95. It's needed. It will never pop. ARDS lung, which is not a pneumonic or a bulla, is not there, emphysema, it's not going to pop up. There is no evidence that higher PEEP causes pneumothorax. So feel free. Use this thing. Use this ARDS net PEEP scale, lower or up, or higher PEEP scale or lower PEEP scale, whatever. So all kind of theory to where to keep which much PEEP. So basically, super syringe to esophageal balloon to whatever to find out the ideal PEEP. So you can do one thing, all kind of theories are available. If you are following a PEEP scale, that you will be somewhere there in the zone 2. Zone was, and zone 3 you don't like to be. This graph is common to all. So basically, what is the plateau pressure? This is the pressure which alveoli sees, and the plateau pressure more than 30, the only knob you touch is tidal volume, which should go down. And, keep an eye on plateau pressure every 6 hourly. Sedation is very much important than, painkillers are more important than sedations. This is how you calculate your plateau pressure. There is a button there. Every machine has a different button. So you, inspiratory hold button, you can calculate the, now use dopes. This is one of the mnemonics, it's very common. Any patient suddenly or desaturating, use this mnemonic, use dopes. Sudden desaturation or collapse patient on ventilator is disconnection, patient, you are called to see a patient who is suddenly desaturated to 80%, so you think of disconnection first or dislodgement. Then obstruction of the tube or any circuits from that, think of obstruction. Pneumothorax is a possibility. Your equipment might fail, and this is the auto PEEP of static breaths. Other types of PCV, whatever, and there are so many modes, APRB, bilabel, bivent, they call it 3 names in one mode, combo modes are there, ASB, prone position, high frequency oscillatory ventilation, plus prone, pulmonary vasodilator, nova lung, and one good thing is coming off is e-ventilation or ECMO ventilation. You basically put the patient on ECMO and rest the lung to a very minimal tidal volume, 4 breaths per minute, so lung is protected. This is the way where you treat severely lung is injured or very bad lung. Thank you very much.
Thank you, Dr. Piyush, for giving an overview of the current ventilatory strategies in ARDS. ARDS is not so uncommon condition. I think one does encounter in the ICU, particularly I think it is very common after the viral infections. And I think now it is a known fact that everyone should be ventilated according to the low tidal volume lung protective strategies, that is 6 ml of predicted body weight. And I think the best is when a patient comes, the sister should write down the predicted body weight on the file, so it is easier. But if you go around, as he said, very few people are practicing the low tidal volume strategy. And many a times we never come to know that the high tidal volume which we gave maintained your oxygenation, made you happy, but cause the ventilator-associated lung injury, which is a precursor or which can trigger the multi-organ failure by the biotrauma and other things. So it is very, very important that to practice, and it is not very difficult. And I think the concept of permissive hypercapnia, that you tolerate high carbon dioxide up to a pH of 7.2 to do a safe ventilation. You can go the respiratory rate up to 35, and if it is still not maintaining, then you have to go for the other strategies. You know, there would be patient of ARDS where you ventilated according to the lung protective strategy. He is not maintaining the saturation. Up to 85 or 84, it is all right. You know, I managed almost 100 patients of H1N1. If it's a slow rise in, a slow drop in the oxygenation, people tolerate very low oxygen without having any hypoxic damage later on. So up to 85, 87, if you are doing the safe ventilation and you are treating the primary cause, you are addressing the primary cause, that you can tolerate in that patient. But if it is not occurring, and you have experience, because the moment the FiO2 goes beyond 0.7 in a ARDS patient, our people start thinking of other things. You know, one thing which you must do is, now there is a paper also that first 48 hours, you must give a neuromuscular blocking agents. You know, they were being given to every patient, then now there is a tendency not to give these drugs. There is a paper which was published that when they gave the neuromuscular blocking agent for first 48 hours, the mortality in that group was less. So in first 48 hours, you should give the neuromuscular blocking agents. Suppose my patient is not maintaining, and I am giving the, according to the low tidal volume strategy, the next step would be to give a high PEEP. If the PF ratio is less than 100, you can get a high PEEP. Not according to the ARDSNet table, but according to the alveolar study table. You know, there were a lot of studies whether to give a low PEEP or a high PEEP. The meta-analysis is that now the recommendation is that a PF ratio, PaO2 FiO2 ratio is less than 100, the high PEEP improves oxygenation and decreases mortality. There are various ways to give high PEEP. I'll not go into details of that, but I think the easiest is, like we have ARDSNet study, similarly there is an alveoli study. In the alveoli study, you just follow the high PEEP arm to give your PEEP, high PEEP as per the oxygenation, FiO2 PEEP, high PEEP. This is, I think, the easiest way to give it. Suppose your patient is still not maintaining. The other thing which we practice is the recruitment maneuvers. And recruitment maneuvers also have not been really proven to decrease mortality, but they increase definitely the oxygenation. And the easiest to practice is the CPAP of about 40 for 30 to 40 seconds. If, of course, the patient should be sedated, patient should be not hemodynamically unstable, he should not have bullas in the lung when you do a recruitment maneuvers. And then after that you put a high PEEP. This is the, if still patient do not maintain, then we always prone. And I think it is very important for every person who is ventilating to learn prone, treat your system. I think we're practicing for the last 12 years, and this is one of the most effective. Even if you don't do all this high PEEP and things like recruitment, put the patient prone. It's very easy, and it helps in many ways. I have seen always, most of the patient will have response, and then you can even do recruitment maneuver in the prone position. I think it is, if there is a seriously ill ARDS patient, before going ahead, he must be prone rather than going to the others. Then, as he said, APRV and pressure control, inverse ratio ventilation can be tried. The problem is, you know, the turnover in our ICU is too high. The residents are not trained in these new modes. Unless everyone knows about these modes, you should not try, because you will put the patient on APRV or the PCIRV, simple APRV, and if they don't know, in the middle of the night they'll call you and you'll put them back onto the assist control, volume ventilation or the pressure ventilation. The other thing is whether you use a volume control or a pressure control, the similar outcome, so long as you aim for the 6 ml per kg body weight of the tidal volume. Then we have done high frequency ventilation. That is another, because it gives you a high mean airway pressure without injuring the lung. So, but there are 2 trials, Oscillate and Oscar, did not prove the efficacy of the high frequency ventilation, but this is a modality still not gone, one can use if it is available. Then of course nitric oxide In certain centers, they are using nitric oxide because it increases the pulmonary flow, so that VQ mismatch is less. It improves the oxygenation. All these may not be available in most of the centers, but these are the modalities which could be used. I'll jump on to the ECMO. I think this modality I have used in about 8 patients, and we've been able to salvage out of them only 2 because of the learning curve. And I think this modality will come. Probably it is more useful in viral infection, because whenever the viral infections come, I need the need of ECMO. Otherwise, around the year, because most of the patient will die of multi-organ failure rather than hypoxemia. So, because viral pneumonias, they cause a single organ failure, severe ARDS, where ECMO definitely has a role. And I think this modality, as the more people learn, will also be there. So, but the basic thing is, as he said, his 4 points, and the low tidal volume, lung protective strategy remains the mainstay. And if it is not effective, then you should go for the rescue. And out of that, I think recruitment, high PEEP and prone, that one must practice. Thank you very much. If there's any question, I'll ask him to answer.
Yeah, absolutely. Fantastic, Dr. Chawla, for that summary of the whole lecture. And I think Piyush has made it very simple. I mean, he does try to make it simple, but he was also forced to make it simple because he can go on. I mean, he can go on. And I think it's very, very important to keep things simple, because we actually not only have intensivists, we also have people who actually just do pure anesthesia. Any questions for Piyush? Vijay.
Thank you very much, Dr. Piyush, for making life of a learner a bit easier. To make life a bit more easier for us, better said than done. Choice of drugs for analgesia and sedation. We all know that pain relief is much more important than sedation. But what are the choice of drugs which provide?
That's a very good question. Acute event, you are intubating a trauma patient.
Sir, drugs, please.
Coming.
Sure.
It's fentanyl. For analgesia, post-intubation, probably fentanyl is good. For sedation, propofol is very good. Dexmedetomidine, Presidex, is good. Probably we are running away, going away from midazolam and all those delirium, once the sedation is getting longer. So other than, benzodiazepines, rest of the newer drugs looks okay. And, ketamines, very low doses also helps. So fentanyl is a very good drug post-intubation. If you want to give any more opioids, remifentanils, all of the ICU, they use. But hemodynamically unstable patients, trauma guys, so you can use fentanyl to start with. Any of the morphine, morphine can be used. But in our ICU, after intubation, after fentanyl, we put the patients on remifentanil, and we avoid benzodiazepines, although we need it most of the time at the night and initial phases, but while weaning period, while the liberation of ventilation starts, we get out of benzodiazepines.
Sir, that's what we do in our ICU. Remifentanil is the choice unless the patient is very hemodynamically unstable. Propofol, more hemodynamic instability. Midazolam, more sedation. Dexmedetomidine, still we are in a learning curve for the ICU usage, and there are certain centers which do not use it for more than 24 hours still, because the pamphlet doesn't allow it.
No, now the recommendation from FDA has approved it to more than 7 days. All right, we can use it. The pamphlet is old printed one. Okay?
So you got the answer now then.
And the importance of sedation vacation. How frequently to be used, and is there any real advantage before we are actually going to wean off the patient?
Yeah, okay. There is a lady doctor from Canada called Sangeeta. She did a very nice study. They negate the result of sedation vacation. But unless you do a sedation vacation, you are not going to know your patient is ready to be extubated or not.
Let me reframe it. Apart from assessing the neurological status.
No, you will get to know everything. If you stop the sedation, then only you can put on spontaneous mode.
The patient continues to be sick.
Yeah.
You don't need to.
He's not fit enough to be for even of a trial of weaning yet. So is there any recommendation to do a regular sedation vacation? And does
still
it
the
improve
recommendation
outcome?
Yeah. If you see the VAF guideline, sedation vacation is always there. It has not gone out of the guideline. As long as it is there, it's guideline, do it. It has, I mean, drugs are getting cleared from the compartments. So basically, you know, next dose of sedation, we can try the lesser dose. And unless it accumulates and you have a tachyphylaxis and goes up and you step up your remifentanil, what happens? It goes up, and sometimes you'll end up in 500, 1000, right? So, you know, if you don't stop it for a while or change your drug to another, the remifentanil will not be, you know, will not be working well.
Thank you, sir.
You know, the other thing is all these patients should be sedated, I mean, given analgesia so much so that you can stimulate and they are awake.
Yes,
you know,
yes,
don't try
minimal
to,
sedation,
and you know,
yeah.
I can tell you, you know, I don't know, I mean, it's a practice. If you go to our gastro ICU and a medical ICU, you will find that hardly any patient in a benzodiazepine, because after the initial part, the fentanyl alone is enough. I mean, that's what I realized. And depending on if it's a short time or, I mean, dexmedetomidine is a really good drug, as he said. There is still learning, and people are scared of cardiac side effects. I mean, if somebody has faced, he's very scared of using this drug.
Yeah.
Okay. I think we will leave. Oh.
It is
Atracurium.
Cis-atracurium. Sorry, cis-atracurium.
Yeah.
That is the study done in 2000.
Study was done on that. But
It's cis-atracurium is not available in India.
Yeah,
I think,
that's why I'm saying we
that's
use
the problem.
atracurium.
But yeah, it's a purer, cis-atracurium is a purer molecule. I think we can continue, like I said, you can continue your discussions.
Rest of the Facebook.
Yeah, Facebook, yeah. Dr. Chawla has to actually leave for another meeting. He's a busy guy. And he has to go to another, I think, lecture or workshop, something like that.
you know, Gangaram is also having a critical care meet.
There you go. So he's going for another meet. Thank you very much, Dr. Chawla. It was really entertaining to have you here. And I request Dr. Dua to actually give our memento to Dr. Chawla, please. Dr. Dua, please. Thanks.